Every physician and office manager already feels it. Your patients with 2 or more chronic conditions are falling through the cracks, and your staff is stretched to the breaking point trying to catch them. According to the CDC, 60% of U.S. adults have a chronic condition. 40% have 2 or more, driving 90% of healthcare costs. But Medicare's chronic care management program reduces hospitalizations by 15%, lowering costs by $74 per beneficiary monthly. The clinical and financial case is ironclad. But executing these care plans requires dedicated staff, focused time, and consistent workflows, 3 resources that growing mid-size practices are rapidly losing. When care plans fail, it is not a lack of dedication. The work is simply too heavy and too prone to disruption every time an employee leaves. It is a severe structural capacity problem. Care plan management requires precise, continuous monthly contact with your most vulnerable patients. But that highly labor-intensive workflow is colliding head-on with modern staffing realities. MGMA data shows front office and medical assistant turnover hitting a severe 40%. And the replacement costs for just one of those frontline staff members quickly climb between $25,000 and $30,000. But the cost goes far beyond just hiring. Every week, a care plan coordinator's seat sits empty, diabetic and hypertensive patients go uncontacted, their care gaps widen, and their risk of hospitalization rises. To fill the gap, the burden shifts to the physicians. Data from TBRA's physician burnout survey shows the strain. For every 15 minutes a physician spends face-to-face with a patient, they spend 9 minutes charting in the electronic health record. That ratio is entirely unsustainable. According to the American Medical Informatics Association, 80% of physicians explicitly agree that this heavy documentation load actively impedes patient care. The traditional model of piling administrative follow-through onto an already stretched in-house clinical team guarantees provider burnout. Making a monthly care plan phone call sounds straightforward. In reality, it involves navigating a massive labyrinth of administrative requirements. It means pulling specific patient panels from the EHR, verifying constantly changing Medicare and secondary insurance eligibility, tracking time to the exact minute for billing, and maintaining compliance with CMS codes that update annually. Tying these purely administrative tasks to nurses or medical assistants creates an immediate bottleneck. When the clinic gets busy, documentation is the first thing to slip, resulting in incomplete records and missed patient outreach. High-performing practices solve this by physically separating the work. They decouple clinical decisions from administrative execution by utilizing a dedicated remote team to handle the paperwork. By stripping away the administrative layer entirely, practices return their in-house staff to the single thing that actually requires their presence: medical judgment. Staffingly operates on this exact decoupled model. They provide practices with a dedicated remote care plan specialist who takes total ownership of the administrative load. These specialists work directly inside your existing EHR system during your regular hours. There are no new platforms to buy, no separate logins to manage, and 0 learning curve for your current staff. The remote specialist executes a structured 4-step flow: logging daily documentation, coordinating precise monthly patient outreach, actively managing eligibility status, and generating automated weekly compliance reports. Enhanced by AI, Staffingly's priority engine automatically ranks care plan tasks, pushing patients with the highest clinical risk and closest billing deadlines to the top. Behind the scenes, AI automation runs continuous compliance checks on every deliverable, eliminating the need for manual quality assurance. A highly specialized human workflow backed by intelligent automation creates an error-resistant, scalable operation that no standard mid-size clinic could sustain on its own. Let's look at the financial reality of this operational shift. Hiring a dedicated in-house care plan coordinator averages $60,800 yearly, stacking up base salary, benefits, and turnover costs. Compare that to a Staffingly virtual medical assistant, a predictable $21,600 per year, resulting in a 64% reduction in total overhead expenses. That is $39,200 in direct annual savings, and that single flat rate fully covers training, benefits, account management, and reliable backup coverage, so the seat is never left empty. Fixing this capacity problem transforms an expensive, fragile operational drain into a highly profitable, sustainable system. Now, the final concern for almost any practice manager is the understandable fear of a long, disruptive, and costly onboarding process. Staffingly bypasses the traditional lag. Practices go live within 48 to 72 hours, utilizing a brief 5 to 7 day parallel launch period to ensure the remote team perfectly matches your specific clinic protocols before taking full ownership. Patient data remains strictly protected. Operations are fully backed by HIPAA, SOC 2 Type 2, and HITRUS certifications, ensuring enterprise-grade safety for your records. You can verify the accuracy and the financial return of this model inside your own clinic using a 30-day risk-free pilot requiring zero long-term commitment. The most effective practices don't try to hire their way out of a broken process. They structurally evolve how the work gets done.